excited to welcome to the stage Dr. Richard McLeory. He is the Executive Vice President of Medical Affairs and Chief Medical Officer of United Health Group. And he's also part of the United Health Group Innovation Council. So he's going to have a lot to share on this topic. So welcome him to the stage. Thank you.
Thanks, Jill.
I'm going to add some pen to the clock for you.
Okay. Good morning. You know, I'm not quite used to working from a podium. I was a surgeon, so I was more likely to be working off of a pedestal. But I think we'll make do. So forgive me if I walk around. Listen, this is a pleasure to be part of this conversation today. And what I'm going to share with you is a story of progress. And with all progress comes risk. I'm going to show you the growing impact, and the stats you just saw were those that helped to start recognizing that the world's economies continue to advance, all from different starting places. But as they do, something evolves. You see, death from infections starts to go away, and all of a sudden you're left with diseases that are the result of long-standing behaviors. And when those long-standing behaviors become manifest, they end up in those 38 million deaths from chronic disease. And these non-communicable diseases is the World Health Organization way of saying chronic disease. They're long-standing, they have roots, and many of them have opportunities for their reversal. In fact, if you were to look at those 38 million deaths, some 28 million of them, about 75%, are occurring in those countries with emerging economies. You know, the lower and the mid-level income countries. And when you start thinking of that, that's a disproportionate burden on those smaller countries. But think about it a little bit more this way. Think about premature death, and we're going to call that death before age 70. And if you look at that, of the 38 million deaths from non-communicable diseases, some 16 million, or about 42%, are borne by these smaller countries, or these smaller economies. All right? In fact, of those premature deaths, 82% come from the smaller economies. Now, what are these deaths from? Cardiovascular disease, that's death from cancer, death from respiratory diseases like COPD and the like, and then finally diabetes complications. And so when you start looking at that, and that counts for about 85% of all of those chronic disease deaths, you start seeing a pattern. That pattern wasn't much different than what we face. And what we're seeing is the rest of the world, as their economy grows, we're all starting to look global in terms of our behaviors. If you were to go back and start looking at what drives those deaths, it's the same thing we've seen in our own economy. Tobacco, inactivity, diet, and then a variety of other behaviors that we put ourselves at risk. We can be our own worst enemy. So if you're going to try to reverse that, and things are starting to look the same, well, our theory is well, maybe we can extend the wellness programs which have matured in the bigger economies and make them more scalable and more apparent. For that reason, technology has never been more important into advancing healthcare. We think, following a variety of studies that have been done by broader economic experts, that about 24% of healthcare expenditure can be reversed for these smaller economies by extending people's lives, making them more productive. We certainly saw it when infection was handled. We anticipate you start handling the chronic diseases, there's more in those economies. As a corollary, if those economies aren't working, then you're going to end up making the problem worse. So let's bang through some of this stuff. This is a map that shows you country by country, country by country incidence rates of these non-communicable diseases. The 5 biggest are Turkmenistan at over 1,000 per 100,000 Kazakhstan, it's Mongolia, Sierra Leone, and Guyana. And in those countries, there were anywhere from 900 to over 1,000 deaths per 100,000 lives in the country from these diseases. Compare that to the US, where it's about 450. And if you look at it from the standpoint of Canada, where it's about 300. So it's about 1/3 the size of that kind of disease burden. Now, so let's say we are going to approach it the way we would approach it in this country. This is the basic ways in which we align our investments. First one, get the population as healthy as they can be, irrespective of where they're starting from. All right? And when they do that, they become more productive and they're not consuming healthcare resources. When they do need healthcare resources, give them tools and advocacy so they can make better decisions about where to go for their problem, what to use for their problem, and what to pay for it. But the third thing, and very importantly, is something that gets forgot about a lot, which is let's arm the people who are going to be providing care with that same information. So when those patients show up, the physicians and other clinicians taking care of these patients are at the top of their game. Now, the way in which we approach it at United Health Group was first off with the anatomy slide, the way in which we built the company. We have 2 business platforms, one of which is United Health Care, which serves about 50 million people itself through benefit designs. And in those benefit designs are structures that are modernized to encourage people to take better care of themselves, as you'll hear later on today, but also to make good decisions about how to use the system. But on the other side is a differentiating platform for us, and that is Optum. Optum's job is to operate on the entire system. And when we describe the entire system, it's the people who seek care, the people who pay for it, and the people who deliver it, as well as other important parties. But those are the 3 main character groups. And we rely on 3 core competencies. And one is clinical insights. We have 18,000 physicians in the company. We should know something about medicine. Second thing is the technology. Technology that processes vast amount of information. But most importantly, it's the final thing, the knowledge that gets applied as we take massive stores of data and convert it into a virtual medical record room. Give you some prospects on the size of this. We serve some 200,000 employers, associations, government agencies who are buying healthcare benefits for a population for whom they have responsibility. That population between our 2 business platforms is about 133 million people, and they're being served by 1 million physicians, not just in the United States, but elsewhere. To do that, we have to have a substantive workforce, and it's about 240,000 people, and I told you about the clinicians as a part of that, but an equal number of technology experts. We are in 125 countries at all different levels of participation, including serving 5 million people for their benefit needs in Brazil, but also in other countries, whether it's even as small as taking care of expatriates and the like, or even providing services to small communities. That has all given us 2 things. Number one, a lot of experience, but the other is reams of data. On a given year, we will produce about 600 billion electronic transactions. That's 600 billion. That works out to about 19,000 a second. And all of those transactions tell us about healthcare consumption. In order to interpret what's going on there, though, we have to spend some money. And we spend about $2.9 billion a year to collect that data, to analyze that data, and then to put that data to work to help people who deliver care, people who seek care, and people who pay for it make better decisions. So let's show you a little bit about that. If we're going to take a population, the first thing you want to know is you want to characterize the illness burden and financial consumption. So we use a process called heat mapping. This is in a tool called Health Plan Manager, where it takes any population that you serve and starts breaking things down by looking at a heat map of the variety of costs for the various conditions that are driving that cost. The size of the boxes here represent the size, are proportionate to the size of the expenditure. The color of the box shows you how rapidly it's changing. So although cardiovascular disease is bigger than diabetes, I'm more concerned for this particular population about diabetes because it's changing faster. We'll prioritize whatever's big, whatever's changing, whatever is different than we expect. We can also use this same tool to look at 57 different behaviors that people make. Do they use wellness programs? If they're diabetic, for instance, are they getting do they have primary care physician coverage? Are they getting their lipids checked? Are they getting HbA1cs, their eyes and their kidneys checked? And we can tell what proportion of the population is up to speed and which ones aren't. And we can even tell you where they live. And using this kind of a data tool allows us to drill down on when people are not doing the things that they need to do to ward off non-communicable disease. This makes no difference what element it is in. We've applied this in the UK, we've applied this in Brazil, and we've done experiments in a variety of other smaller countries to get a sense of, can this be applied? And it does. The other thing you want to be able to do is to look at the entire population on an individual basis. Go down to the basic individual and collect every piece of data that we have about that individual and put it into a file that we can then interpret and for what conditions they have. And since we know their claims and all, we also know how they've been evaluated, and we know how they've been treated. And that way we can start finding errors that turns into such things as gaps in care, medication mismatches, lack of adherence, and the like. And for every individual, we have the ability to list out everything that individual needs to do and then rank order them by the actuarial value of having changed that problem. And then you spend your time, and this is where the technology comes in, getting it into their hands. In order for us to be able to approach the smaller economies around the world, we have to rely on these kinds of technologies. But we have to rely on one other piece, which is the ability to help their physicians be able to manage them as well. There's nobody more persuasive than a physician in a patient's eyes. And if you were to give the same information through a cloud-based setup, which is infinitely scalable, as we are doing now, we can help physicians to be able to look at their entire practice. In this particular instance, this physician is looking at every diabetic in his practice. And to rank order them, here we decided to do it by HbA1cs. And you can pull up a given patient and look, because the technology that we use not only imports the claims data that we see, but also scrubs the electronic health record using natural language processing to identify other opportunities. It'll show you every abnormal lab test or every abnormal finding within the record, including that which is only written in text. It'll also show you patient traffic patterns, what happens when the patient's not in the office. It'll also predict what's the likelihood somebody will be hospitalized during the course of the year. And as physician groups become more and more organized all over the world, you can also provide physicians with something they've long been lacking: solid statistical reflection of their practice, both on the basis of quality and on the basis of cost. The final piece is this: the ability to engage consumers in a way that helps them understand their navigation and their needs. all in their pocket. This is a tool we've shown you before. This is something called Health for Me. On this tool, we have the capacity to do telemedicine, which is invaluable. It can also show you, or any user, where the closest delivery system is by type, be it something of an urgent nature, something of an inpatient nature, something of a primary care nature. It'll help identify physicians in the area anywhere. It can help the patient by understanding their biometrics and their abnormalities. It can also help people understand such things as their own personal health record. Excuse me, I think I got a gap. When you start looking at these tools, they become powerful because it not only closes a gap, but it also shows you how to enable it. So we call these our enabling technologies. And it's through these kinds of technologies that are infinitely distributable that you have the ability to take the insights from those powerful analytics, to put them in the hands of the patient, put them in the hands of the physician, to make sure that when those two people contact each other, the likelihood that they're going to fix something is driven to a higher level. If you're going to approach smaller economies, particularly economies that are less densely populated, this will be the only way you're going to be able to get there. You can change the sophistication of this thing to be a broad-based medicine, as in the case here, or even on a specialized basis, as we have capabilities to focus only on pregnancy, as well as to focus on such things as pharmacy management and the like. So like I say, these tools are there, they're expanding. The likelihood that you have smartphones in the hands of these economies is fairly high. This is a powerful point of leverage if you're going to make a difference in non-communicable diseases on the earth. So I thank you for your time, and I'll turn things back over.